Hello and welcome to today's McMaster University Continuing Education Caregiving Essentials webinar, All the Ways a Geriatrician Can Help. I would like to begin by acknowledging the land on which we reside. McMaster University recognizes and acknowledges that it is located on the traditional territories of the Mississauga and Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum Agreement. My name is Jennifer, and I'll be your host on behalf of McMaster Continuing Education. Today, I am joined by our facilitators, Donna Thompson and Dr. Nicole Didick. Without further ado, I'd like to introduce Donna Thompson. Donna is the co-author of The Unexpected Journey of Caring, The Transformation from Loved One to Caregiver, and the author of The Four Walls of My Freedoms, Lessons I've Learned from a Life of Caregiving. Donna is a patient and family advisor on health research and policy, and she teaches family caregivers in Canada how to advocate for care in a hospital and in the community. She blogs regularly at the Caregiver's Living Room. Donna is the facilitator of Caregiving Essentials and Infection Prevention and Control for Caregivers and Families, our free online courses for family caregivers. And I would like to introduce to you Dr. Nicole Didick. Dr. Didick has been a geriatrician internist in Waterloo region since 2004. Prior to that, she worked in Calgary and Hamilton. After completing medical training and residency at McMaster University, Nicole is an associate clinical professor at McMaster and has been involved in medical education at the Waterloo Regional Campus. Dr. Didick's passion for education has led to the launch of The Wrinkle, an online educational resource for older adults, their care partners, and health professionals. Catch up with her at www.thewrinkle.ca. And without further ado, I'd like to hand things over to Donna.
Thanks so much, Jen. And welcome, Nicole, Dr. Didick. I am so excited that you're here today. And as regular, people who attend the webinars here at McMaster Continuing Education know, I usually just invite my friends to join here, friends who are in the trenches of caregiving, I would say, and who are experts. And so today, I'm just intrigued to talk to you, Nicole, about the field of geriatrics and the role of a geriatrician for people who are older, who may have a diagnosis related to aging. And I'm hoping you can tell us, first of all, what is a geriatrician, and what do you do, and what is the field of geriatrics actually, and how does it differ from other sort of general medicine?
Absolutely. Yeah. So thanks so much for the opportunity, Donna. And, it is really a privilege to be included in a group of experts when it comes to caregiving, because, I've had some caregiving experiences of my own, but most of my work is on the other side of of sort of the relationship of coming from the medical professional side. So thank you so much for that. And thanks for the opportunity to talk about geriatrics, because it's a pretty young specialty. It started in the UK, actually, in Britain, and it kind of came out of internal medicine, which is, we sort of say it's everything from here to here. So it's everything kind of from your neck to your pelvis, all the internal organs. So it includes things like respirology and cardiology and gastroenterology. So an internist looks at, the body that way, but a geriatrician looks after that from the point of view of an older adult. And it's different. So it's the same way that pediatrics is not just small people. Geriatrics isn't just, regular adults who've lived longer. So there really are a lot of things that are unique to looking after older people. So I wonder if we can advance the slide, please. And because I just have a couple slides and this is me, and if you don't have time to jot all this down, this is being recorded. You can always pause it later and look at all of my socials, but I would love to hear from you on there. And so the next slide, we'll get back into kind of what is geriatrics. And this is one view of what makes looking after older adults different. So it's not just looking at one problem or one system. It's looking at the multi-complexity. So that's why this model is so good, because it's like your hand, and there's the 5 fingers and then five things that start with M, because medicine, we love to make acronyms and things that people can remember easily. But the multi-complexity is really the crux, I would say, of geriatrics, because it's usually so, and we see people with syndromes. So we don't necessarily just see people with a certain disease. We see people with a symptom or a syndrome. So an example of that would be falls. When someone's falling, it's usually not one thing. It's usually a bunch of things that are all kind of interacting together to make the person unstable. So that multi-complexity or frailty is a big thing. We always look at medications. And so, and geriatricians, we kind of look at all medications. We don't just, as a cardiologist, you might just look at the heart meds. We kind of look at everything. And we like to say that we stop more pills than we start, because, a lot of times people are on the same pills for 30 or 40 years. Maybe now that the person's older, it's not appropriate. And we look at practical things like the mobility of the person. So, we might, and again, not to be critical of other doctors, but we don't just look at the lungs. We look at, okay, well, how is the person getting around? So despite all of their conditions and despite all of this multi-complexity, how are they getting, how are they moving about, getting from place to place, getting out to the activities that they need to do? So the mobility is something that not every doctor looks at, but a geriatrician does. And then the mind is a big one too, because, and when I was considering geriatrics, I thought of being a psychiatrist because I loved the brain and I loved the mind and behavior. But I thought, I can't ignore everything that's below the neck. When I want to figure out what's going on with the mind, I have to look at everything else. And so when we look at things like dementia, with Alzheimer's being the most common type, when we look at things like delirium, which is temporary, confusion because someone's sick, depression, all of those things that relate to the mind, we have to look at everything else too. So geriatricians always would kind of screen in that domain to make sure that everything's okay. And then finally, it's the matters most finger. And that is kind of the most important thing. It's funny that it's number 5 in this particular model, but we get at what matters to the client and the family and their community. So it might not be curing something, or it might be getting rid of the earwax so that the person can actually hear when they go to church, or it might be getting the person a ride to church that's accessible, or helping the person figure out how to broadcast their faith community service, when it's on Saturdays. So it's really what matters to the person. And a lot of those things don't sound very medical, do they? But in the geriatrician's office, we have to think outside of the box and kind of make it happen in terms of what matters most to the person.
Mm-hmm. It's so interesting, Nicole, because I'm looking at that list and I'm thinking this is all the stuff that family caregivers do too. Yeah. Like the family caregiver is the ultimate generalist. And is the one often that is the keeper of the corporate history of the person, the medical history, the context of a person's life. And all of these 5 domains are, so I can see I can feel a sense of relief. Like I can actually, this is somebody I can actually talk to about the whole person. And which is just fantastic. That's the first thought that came into my mind, looking at this list and hearing you talk about it, is that here is somebody who is exactly on the same page as the family. And of course, the patient who was, I mean, people are people. It's everything about the person. So, and the question I had looking at this list is, when you're seeing a geriatrician and there is an issue, say, that impacts the lungs, do you still see a respirologist? Like, what is the role of specialists in the context of when you're seeing a geriatrician? Do you still see specialists?
That's a great question. And it really does depend on, again, what matters most to the person, right?
Okay.
So a lot of times, so sometimes I will do an assessment. It's pretty lengthy assessment. It's usually about 90 minutes or so for the initial consultation. And sometimes I will give my recommendations and then, send the person back to their specialist and their primary care provider with those recommendations. But sometimes having a discussion with the patient and the family, we sort of realize that, the work that we can do in the geriatric clinic, it might be more meaningful and more appropriate than following up with a specialist. So there's a little bit of negotiation there. We, as doctors, we don't want to, step on toes is the term that we use. Like we don't want to say, oh, you don't have to see that doctor if there's been a relationship there. But you're right. A lot of times the geriatrician can be a bit of a generalist as well and can manage things like the blood pressure, the diabetes, the heart failure, for example. And it can be a one-stop shop. And then we really do work in a team as well. So a lot of times we will see the person and do, as a geriatrician, I'll do that big assessment. And then the follow-up might be with a nurse or a nurse practitioner for some of the, to meet some of the goals. And then the nurse practitioner will collaborate with me. And then I might see the person again at some point. So it's very much a team, a team effort. And working with the family too, because, that's interesting, Donna, what you said about these are the caregiver roles. And you can't do a geriatric assessment without interviewing the family and getting the family's perspective. It's the first thing we learn. Yeah.
Yeah, I love this. I love this.
You've got to do it.
I'm going to just read a couple of comments from the chat too.
Sure.
Barb has said that she's been caregiving for 35 years now. And started with her mother-in-law who lived to 97, great mind, but her body failed. Currently, her sister-in-law, 75, with cerebral palsy and in long-term care with excellent medical capabilities. And her mother with advanced Alzheimer's coming up to 92. And all this information is so helpful to apply. Maggie is saying, it sounds like a geriatrician is not a primary care provider. Can you clarify that?
That's a great question. So yes, in Canada especially. So in the US, yes, some people will have an internist or a geriatrician as their primary care provider. But here in Canada, we're specialists. So the training that we do is a bit longer. We do 3 years of it. We do med school and then 3 years of internal medicine and 2 years of geriatric medicine training. And then we work as specialists. So yes, it's not like I have I don't have a family practice, so to speak, but we work very closely with the person's primary care provider, whether it's a doctor or a nurse practitioner, to give the care. But yeah, it's in the US, it's a bit different.
Okay. Thank you for that. So tell us more about what you do exactly in your role.
Sure. Well, let's go on to our next slide, maybe, which they're a little bit repetitive, but this was another sort of view. And this was by Bernard Isaacs, who was one of the fathers of geriatrics in England. And so he, instead of the 5 M's, he had these I's. And I kind of like this because he brings in incontinence, which is another big issue that a lot of people don't, urologists and gynecologists deal with it, but a lot of times it gets overlooked. So that's something we always ask about in our assessment. And then again, the giants, they're the syndromes, right? So falling, the cognitive changes, problems with the bladder, problems with getting around, deconditioning, which is kind of a nicer way of saying weakness. So all of those things are the kinds of things that would get a person a referral to come and see me. And sometimes it's a bunch of, sometimes it's all of the above. And we have to try and iron that out.
Sure.
And and so what I find, so we do a long assessment. Like I say, it's usually about an hour and a half. It involves an interview with the person, an interview with the care partner, who is often a spouse or a child or both. And then we do a physical examination, usually a pretty thorough physical examination. We often do cognitive screening in the office. So I might do, a test of some of the brain functions, like drawing a clock or copying a design or remembering a few objects. And I might do some other screening tools too, like I might screen for depression, ask a bunch of checklist questions on that. And then I give some feedback to the patient and family about what I think is going on and what I suggest that we do. So that can be hard to pack into an hour and a half, but it's longer than most appointments, I think. Yeah. And the exciting thing is too that, when I'm solving one of these puzzles, so when I'm seeing someone and they've got this list of things that are going on, it's oftentimes not just one thing, it is multiple things. And sometimes that's met with frustration by someone, because I think it's really satisfying to be able to have a problem and go see someone and they say, oh, you've got, rhubarb disease, and here's the drug that'll fix it, but in geriatric medicine, it's usually like, well, it's actually that your vision's not so great and your hearing, you need to use your hearing aids, and your memory is failing you, and your apartment is too small and it's cluttered, and, your medications aren't ideal. So it's often these multiple things. But then the exciting thing about that is that we can work on multiple solutions together, right? Mm-hmm. So I love that. Yeah, it's not one thing we can fix, but maybe we can tweak a bunch of things and make a difference in the end.
Yeah. I'm thinking about my mom, who died peacefully in her sleep, waiting for her morning coffee at the age of 96. Wow. She had dementia, but she, she never lost her personality. She had a very strong personality. Mm. And I'm thinking about, what you're saying about sort of complexity and complex solutions. And I remember that my sister and I, we tried to figure this out on our own. We tried to understand what the root causes of her falls and what we should do about that next step of, should we move her out of her seniors residence into assisted living? Like all of these, in the end, we had it, push came to shove, she got evicted for unsafe smoking. So we had, we did an intervention and moved her that morning and said, Mom, you're moving, come now, we're going, which was very difficult, as you can imagine, very emotional. But, if we had had this approach and had her agreement to this approach, much earlier, I think we could have saved ourselves a huge amount of grief and anxiety about, this kind of the complex problems and the complex solutions, to have someone who is helping you through, because as a family caregiver, as you move into these complex questions and issues of aging, you basically, as a family caregiver, we learn by our mistakes. And, unless you've hired, unless you have the benefit of a geriatrician or a navigator or a social worker, or somebody who can guide you through and help you and sort out one problem from another and approach them one at a time and from this complex perspective, it just can be so difficult. And I talk to caregivers every day in online support groups who are overwhelmed and struggling with very complex situations, made worse, of course, by COVID.
Mm-hmm. Oh, absolutely.
Yeah.
Yeah.
But Nicole, you spend so much time offering free support and education to patients and families, which is why I'm ecstatic that you're here today. And I want to just show everybody who's here just a snippet of what you do on your YouTube channel called The Wrinkle, and on your social media. So Jen, can you just play this short video as an example?
If you haven't watched before, my name is Dr. Nicole Didick, and I am a geriatrician. So I'm board certified in internal medicine and geriatrics, and I've spent the last 20 years looking after older adults. Here's an assumption about aging that I hear a lot, and I want to set straight. Kids have a responsibility to look after their older parents. Well, you know what? That's not necessarily true. I meet a lot of people who've had very difficult relationships with their parents for a long time. And somehow when the older parent gets a medical issue and has needs, it becomes the responsibility of the adult child to look after those. And I don't always think that that's fair. If your older parent has been a narcissist or a difficult person, then just because they're older doesn't automatically mean that you kind of give them a pass for that and wipe all that away and come to their rescue, sacrificing your own needs in the process. I think a lot of people in the medical field assume that adult children need to kind of jump into the breach when there's an issue with an older adult parent, but I think that's something we shouldn't always assume. For example, I try to avoid, and I know a lot of people try to avoid using the term loved one, because not everybody loves the relative that they're traditionally supposed to love. So I try to use the term family member instead. So if you're one of those people who assumes that, why aren't the kids doing more? Well, there could be good reasons for that. And, that's the time to maybe mind our own beeswax and not make those assumptions and look for other ways to solve the problem. Another assumption is that old people need to sleep more, and it's okay to have a nap or to spend most of your time in a chair or in bed because you're old. I hate that one, and it's not true. In fact, the opposite could be true. So, I've read some studies that people who tend to sleep more, like more than 9 hours, could be at higher risk for some medical conditions as they get older. It's also true that people can get deconditioned by spending a lot of time in bed or in a chair. I see a lot of people who are spending 18 or 20 hours a day kind of lying or sitting down, and then they're having falls and becoming weak when they do get up to move. So, that's a myth that I would just love to kick to the curb. It's good to stay active at every age. And just because a person turns a certain age on the calendar doesn't mean that it's time to slow down and to stop. It's important to keep moving and find different ways of doing it. So you don't have permission to snooze in my books. Sorry. Older adults shouldn't be living on their own. Well, over the age of 65, only 5% of people aren't living at home in their own homes. That number does go up to about 35% of people over the age of 80. But, most people are living their lives in their own place. So kind of thinking that everybody lives in a home or should live in a home, whatever that is, isn't true. I'm really glad there are things like seniors' homes and even long-term care homes for people who need them. And some people do, but not all of those people are older. And usually going to live there is more related to a person's health issues and abilities rather than just their age. So thinking that just because someone is 90, that they should be living somewhere else other than on their own, that's a myth. There are so many myths associated with aging, right? that all old people have incontinence and need to wear a diaper, that old people are slow, that old people can't hear, that old people are boring. You know, there are some changes that are natural part of aging, and if you watch me here on The Wrinkle, you'll learn more about those, but they're not universal. And some of them aren't related to aging. They could be related to other things. So, you know, I hope that you've kind of enjoyed hearing about some of these myths, and maybe you've learned something, and maybe you can reframe some of your assumptions about older people. If you want to learn more about aging, I would encourage you to go to thewrinkle.ca, where you can see all my videos and maybe learn something else about older adults. Or you can watch the video that YouTube is suggesting right now.
That is just fantastic. Thank you. Thank you, Nicole. I hope everyone does have a good deep dive in your YouTube channel. This idea of busting myths around older adults and aging. I am 67. Can never remember, something like that. And so I'm hyper aware of aging myself. And a lot of what family caregivers do, as you know, is sort of broker the relationship between the patient and healthcare providers, and even with extended family and the world at large. And as healthcare needs arise and we seek the help of medical professionals, ageism is a thing, and it can be a thing with even other family members too, friends, neighbors, and so in terms of being an advocate for your parent or for your spouse, what do you recommend to families? How do you first of all identify ageism in healthcare, and how do you deal with it? What do you recommend? What do you have to say about this issue?
Yes. So, I mean, I do have a lot to say about that. And I think I have a couple of videos on ageism, because you're right, it is really real. And, it's, and when it comes to healthcare, it can really get in the way. So some of it is systemic. So some of it is things like, if we look at the COVID vaccine trials, in a condition that predominantly affected and was deadly to older adults, there were comparatively very few older adults who were frail and living in long-term care who were in those studies. So when it comes to things like recruitment into scientific studies, or even the guidelines that we look at as doctors, they'll sort of be guidelines for people up to age 70. And then after that, it's like whatever you want to do, or if we look at the World Health Organization that doesn't prioritize chronic conditions. They're more interested in conditions that are more likely to affect young people, infections and things like that. When there are billions of people living with osteoarthritis and the disability associated with that, and dementia, is a big issue too. So I think that, systemically it can be a problem. And I hear about it every day in my office too, that, while someone will come to me for a certain complaint, and they'll say, yeah, I really had to bug the doctor because they were saying that it's just my age. What do I expect? Right. Oh. And, and I hate to hear that. And I'm glad that the family member was persistent in asking for the referral, because it's like the joke that, I think this is in one of Bernard Isaac's books, that the 102-year-old man goes to the doctor and complains about knee pain. And the doctor says, well, you've been walking on that knee for 102 years. Of course it's going to hurt. And the older adult said, well, my other knee I've been walking on that one for 102 years too, and it doesn't hurt. So tell me why this one hurts, And
good question.
So, yeah, I think it also comes back when you're doing advocacy in a one-on-one, scenario with a health provider. I think it is very important to report on what the person is like. and what they're usually like. Because when we see someone in a blue gown in a hospital bed who's totally mixed up, it's very easy to assume that that's the way that person is. And so I think it's very important to say, well, 2 weeks ago, they were going to church with me. Yesterday, they ate a great supper and we played Boggle. And, they're living with dementia. So we kind of modify the Boggle, but they had a great time. And today they're not talking and they're not answering and they have a fever. So I think telling the provider about your person, so that they can see them as, this is a change. This is something that we need to address. It's not just them. It's not just normal aging. I think that could get through. It often does to me. Hey, even I sometimes need to hear that, and I really love it actually when people come in and say, let me tell you about Bob. And they don't go on for half an hour, but sometimes they just want to say, Bob's a retired chemistry professor and he loves bird watching. And, he's the love of my life and he's such a great dad. And, you should see his electric train set.
Mm-hmm.
And then I'm working with Bob. I'm not working with, Alzheimer's guy. I'm working with a person that's more relatable.
Yeah. That is so important. And as the mother myself of a young man with severe physical disabilities and who has very, very little speech and is, frequently in the hospital, I would never take him to the hospital without that kind of an explanation of who he is, and that what you're seeing is not his usual. Because I think both age and disability, and if you have those two things together, boy, you really do have a lot of negative assumptions placed on you in the emergency room if people don't know you. And so I always arrive with pictures. And if he's in the hospital, I put all pictures of when he's well up in the room. It draws the nursing team, it draws the physicians to look at them. It's natural human curiosity and say, see that young man in bed is not the same man in these pictures. We want to get him back to the picture version of himself. And videos are really helpful, I find too. And, so I think, again, it's so easy for people to assume, particularly if there's a diagnosis of dementia, for example, that a person gets like a UTI and they tip over into delirium and, I don't know what you officially call it, psychosis of some kind, extreme confusion. And if that's not their normal, people might easily assume that's how they always are. It's so easy to make those negative assumptions.
Yeah. No, it really is, and so, yes, and I'm sure that it's exhausting to, it's probably fun to share all the, nice images and videos, but it's tiring, but that's important work to do as a caregiver. And yeah, to let people know, this is not the baseline. And I think it's especially hard when people don't have that advocate or that caregiver, right? I mean, thank goodness for social workers.
Yeah.
A lot of times social workers, if there is one, on the ward or in the emerge, and they take the time, they have the time to do a bit of digging, they can often do some advocacy too. So
yes. Yeah. I want to touch on as well, this issue of a geriatrician's role to help move through transitions of care. But related to that issue are two questions that we had come in. One is, should all long-term care residents be given a geriatric assessment to assess specific areas to address? That's the first question. So go ahead and take that one.
Well, that's really interesting because oftentimes when someone makes a transition into long-term care, that's often when the geriatrician steps back a little bit. And the primary care, and that's another probably assumption, is that, Jerry, we should be in long-term care more, but most of our work is pre-long-term care. There are people that I follow, in long-term care for sure, but we're very fortunate in a lot of long-term care homes. There's kind of a house doctor who is a primary care doctor or family doctor. Sometimes those doctors have extra training in what's called care of the elderly. So they may have a little bit more expertise in geriatric medicine. And then a lot of those doctors too, I kind of know them, at least in my community, because I do continuing education with them. So they will often reach out to me with specific questions. So I would say the geriatric assessment is good to do, I think, before someone goes to long-term care, to get that comprehensive picture and to highlight things that might come up. But once a person is in long-term care, usually there isn't. I think there's a medication review that's done quarterly by a pharmacist. I think the family physicians are often doing monthly reviews. But in terms of that comprehensive assessment, when a person's in long-term care, we don't really do them. And, I think we could argue that it would be good for geriatricians to be more involved in long-term care if there were just more of us. But, but I do home visits, and I go to a lot of retirement homes, I have to say, which I kind of refer to as long-term care homes for the wealthy. So I would say a lot of my work with frail older adults who would be suitable for long-term care is in retirement homes.
Yeah. My mother lived in a retirement home for many years, like about 15 years before she eventually moved into assisted living. And that's a good description for the wealthy. I mean, $17 for someone to bring you a pill, and every single service of any shape or form is an extra charge there. But so the second question from Barb is, how often should these assessments be done? And in the wake of COVID-19 and the long-term effects of COVID being seen, should the assessment be updated and redone? If you're not sure if you're seeing aging or long COVID for maybe, or the effects of social isolation that are caused by COVID lockdowns.
Yeah, absolutely. I mean, I can completely relate to that, Barbara. And, definitely it's affecting people in long-term care and in the community who are in that older adult age group. There's, and I mean, this is anecdotal, but I haven't really delved into the evidence deeply, but I'm certainly seeing people who are socially isolated, people who have been less physically active and have become physically weaker. People who have, because of isolation, have had more depression, more psychotic symptoms like delusions and hallucinations. It's absolutely been, the isolation has been awful. And even within retirement homes, people having more challenges with behavioral responses, which often leads to people having to leave a retirement home and go into long-term care. So yes, I mean, I think everybody kind of would benefit from a review at this point and a tune-up. And how feasible that is, I don't know, and that's a good point too, Donna, is that sometimes it's hard to distinguish from a flare-up of a medical issue. If there's a chronic medical issue that's been neglected. Because it's been harder to have visits and things like that. So there is a lot of teasing out to do. It's not easy.
So I wanted to back up just for a second and ask you, so when should someone consider first seeing or seeking the help of a geriatrician? What are the signs? Like, so I don't have any chronic conditions, but if I did, like, am I old enough to, like, how do you know that you're supposed to?
That's a great point. Yeah, I mean, and you know what? Age is, so we generally see people who are over 65, but I absolutely see younger people who have, I would say it's those syndromes, You know, it's those geriatric syndromes. So if somebody is getting cognitive impairment, you know, if they look like they're developing a dementia, if they are falling. So, you know, I mean, I don't usually see people in their 30s and 40s, but you know, if someone is physiologically sort of frail and elderly in their 50s and 60s, then we will see them. But by the same token, if you're 75 and you aren't really living with any, you know, chronic diseases, and you're not falling, and you might still be working, and, you know, then I don't know that a geriatrician would do much for you. They might tell you to, you know, stop drinking, or they might, you know, they might look at your pills or things. We can always find something, we geriatricians, you know, but yeah, but in terms of seeing like people who are fairly well, we don't usually have that much to add. Yeah.
So if there was one thing, Nicole, that, you know, in your years of practice, you could say, gosh, you know, if families knew at the beginning of helping an older adult move through the aging process and these aging syndromes, if they knew at the beginning, it would be easier. How might you answer that question?
Yeah. And you know what? It's hard to say that there's just one specific thing, like that would be disease specific or syndrome specific. But I think that, you know, I think a big part of my job is giving clarity, you know, because a lot of what I diagnose and a lot of the syndromes that I work with my patients and families, they're not really curable. You know, they are chronic and they're usually progressive. So my job is to just sometimes provide clarity and say, okay, well, this is dementia, you know, this is Alzheimer's, and this symptom is due to the Alzheimer's, you know, so there's a lot of that clarity, which is pretty specific to the person's diagnosis. I think the one thing that I try to tell people and that I want people to hear as they're starting the journey is that you will do your best, and your best will be enough. You know, and that's something one of my geriatrician colleagues, Dr. Leslie Carnison, says.
Oh, she's great.
Isn't she wonderful? And she's written some great stuff and has a wonderful website as well, Better Health While Aging. But, you know, I think people need to hear that. It's kind of like when I was a new parent, I needed to hear that, you know, that
me too.
Whatever you decide is the right thing. And, you know, and even when there is that transition to long-term care, and then, you know, that's probably the other part of my job is giving people permission. So the one is clarity and the other is permission to say, you know what, it's time to make that transition. Yeah. You've done your best. And, you know, 70% of people who live long enough with this condition move to long-term care. And this just is your time, you know, and it sucks, but we don't have a choice, you know, so giving people permission to go ahead and say that it's time to do that. And, you know, and then I say, don't look back, like don't, except on certain circumstances, you know, if it's a really horrible fit, but just keep moving forward. You know, you're going to second guess yourself, but when you get that bed offer, just move forward and just, you know, go through it. And it's not going to be easy, but it's the right thing. So I guess I want to give people some power and you know, to trust themselves and that they're not alone. Peer support, it can be so important, right? Like learning, I think people learn so much from each other. And I know I learn from my patients and families too. Like they'll say, well, we tried this, or have you heard about this website or this app? You know, when you mentioned you and your sister figuring stuff out, like a geriatrician can definitely give you some guidance, and peers can as well. Support groups like the Caregiver Essentials, right? I mean, you can learn so much from each other, or maybe you can just kind of learn, yeah, you know what, that's unsolvable. Yeah, that's pretty crappy. You know, that you have that your family member, you know, every night they're being incontinent of urine and the bed needs to be changed. That's tough, right? You know, there's no answer to that. Sometimes just knowing that, sharing that and getting someone else's experience is really important.
Oh, absolutely. I'm a full 100% believer in that, boy.
Yeah.
Maggie has a very interesting question in the chat box. She's from the US, and she says, in your experience, are geriatricians more responsive to medical aid, medical assistance in dying than other physicians? And she says she's in the US and doesn't know the Canadian context around MAID.
Yeah, no, thanks. That's a good question. I think I think that's another thing that a lot of people assume, that geriatric medicine is end of life care because we're working with older adults and they must all be pretty close to dying, and it's true, like it overlaps nicely with palliative care for sure, which is usually more end of life care. And palliative care is about treating symptoms, right? So that's a lot of geriatrics too, is that we're treating symptoms, we're not trying to cure. But a lot of our older adults aren't at the end of life, so I think MAID doesn't come up as often as it might maybe in other domains. I think it's very tricky. I mean, a lot of geriatricians have, I think, legitimate concerns about ageism and how that could affect the use of or the requests and the use of MAID with older adults. There is a lot of discussion right now about MAID for conditions, psychiatric conditions, for example, that aren't foreseeably going to lead to end of life, as well as being able to, request MAID in advance. So I would say generally geriatricians are very cautious when it comes to MAID. But I think, we all want to be centered around our patient and client. And if that's something that they want to discuss or, bring up, I think we're open to talking about it. But I think we have a lot of, we want to make sure that for our very vulnerable, potentially vulnerable population, that it's, that we have a voice in advocating and navigating through that.
Mm-hmm. Yeah, I'm completely, I don't have a word to say that in disagreement with any of that. And I think that in the family community, in cases where there isn't a life-limiting illness per se, so in the case of disability, that isn't necessarily a life-limiting in and of itself, or psychiatric diagnoses and so forth, there is a sense in the family community at any rate, and there's a lot of advocacy in Canada on this issue actually, that there's a huge concern that well, let me put it this way, there is a legal right in this country to access medical assistance in dying in those categories right now. And they're expanding it to include older youth as well. And that's pretty imminent now. They're having hearings, but that will go through, I'm sure. And I think there's concern that there is not a legal right to the social determinants of health. So safe housing, access to home care, which has gotten much, much worse during COVID. There's a huge home care shortage. So is life livable with a chronic condition in Canada today? That's the question we have to ask ourselves, I think. And so I think it's very interesting to consider the role of a generalist physician like yourself, like also palliative care, that take this wellness and generalist approach to supported living with a serious illness. How can we leverage the voices that want to support a good life with aging, with chronic illness, as much as we want to support people's choices in the context of life-limiting serious illness. So, that's a national conundrum for us in Canada, I think. That's the context for me.
Yeah.
Anyway.
Yeah. No, I do agree as well. And I think too that, you know, the other thing is that death is so taboo, right?
Yeah.
And so a lot of times, another discussion that I often have as a chronic condition might be progressing is, you know, how and I think people need instruction on how can you help navigate a natural death.
Yes.
For your family member, you know, because our knee jerk is, well, what if they get, so it's good for us to have discussions about, well, what if there is a pneumonia, you know, and the person is living with this, you know, if there's been the progression to this point, what if there is a pneumonia, would you want to go back to hospital, or would you want to have a different path? So when, you know, because people, I think, don't always understand what, say someone who's living with dementia, what does that end stage of dementia look like, and how do people actually die, and how can you allow a natural death that'll be comfortable and, you know, the right transition at that time. So it's not, you know, you can have a peaceful death without MAID, right? But it could be natural.
Yes.
So I think we have to recognize it's not a dichotomy between intolerable suffering and agony and MAID. Right? You can have that in between. And so that's part of my work too, I think, is kind of talking about what could that look like? And then what choices are we going to make along the way?
Yeah.
Yeah.
It's about knowing what those choices are and what those pathways might look like, helping people envision what they have no idea what they don't know. Like, we didn't know this about my mom. We did not know, we had no idea how her life might end. I mean, she had a perfect end of life as far as I'm concerned. I mean, literally, she said she wanted a coffee in bed before getting up in the morning. And then she had a half-eaten box of chocolates on her bedside table. Oh. You know, she had a cocktail the night before. She's like,
yeah.
And
That's
she
lovely.
just went back to sleep and died, you know. And so I think that there is a lot of misinformation about this. And I think there's a huge fear of aging, a huge fear of dependency, the onset of being dependent on other people. And there's a shame in it, you know. Of it is incontinence is a big deal breaker for many families, actually. You know, I think it's tough. This is not for the weak of heart. Supporting people through the aging process. But how can someone find, and this is my last question because we're almost out of time, but Nicole, how could someone find a geriatrician if, you know, they're thinking, gosh, I could really, really use someone like you?
Well, you know what? I mean, so you could certainly ask your family doctor if they know, you know, who does the geriatric consultations in your region. You can, in Ontario, you can go on the College of Physicians and Surgeons of Ontario, CPSO. I think it's cpso.on.ca. And you can find a doctor and you can type in geriatrics and see what comes up. And then there's also the Canadian Geriatric Society that, you know, has I think they have a link to the public where you could ask them, you know, about a geriatrician in your particular region. So we need more geriatricians. Unfortunately, we're pretty concentrated in, you know, certain areas. My practice has always been a little bit outside, you know, in Kitchener, and now it's in Cambridge. So I'm not in the heart of the academic center. So, you know, I'm what's considered a community geriatrician. So there's more and more of us being trained all the time, but those would be the routes, I would say.
Oh, thank you so much. And thank you for this really wonderful conversation today. Everybody go to The Wrinkle, go to thewrinkle.ca, go to YouTube, The Wrinkle channel. And thank you for just being here and giving so much valuable information today, Nicole. And
it's my pleasure.
Oh, thanks. And
thank you for the work you do.
Thank you.
Well, thank you, Donna, and thank you, Dr. Nicole Didick, for a wonderful session today. There's so much to be learned. So thank you.